So, a Viva or intertrochanteric fracture. What is your diagnosis? Fracture intertrochanteric in a 67-year-old female of 2 months duration. Why do you say so? I say so because 2 months back, the 67-year-old female had having some history of back pain suggesting osteoporosis, had a slip and a fall in the bathroom, following which she couldn't get up and walk. There was a flexion, adduction, external rotation deformity with true shortening above the trochanter as measured by the Bryant's triangle. Active straight leg raising test was positive. The patient at present is walking with a Trendelenburg gait. He is unable to squat and sit cross-legged due to limitation of flexion in right knee. This is due to post immobilization stiffness. There was active and passive ankle dorsiflexion which is intact. There is a normal cardiorespiratory status. BMI is about 26 and the rehabilitation potential has got no negative factors. I would investigate by assessing the general condition of the patient, the rehabilitation potential and the cardiorespiratory status. Then I would take an X-ray of the pelvis, AP view with both hips in parallel to each other and parallel to the trunk. So this I will do to ensure the amount of flexion deformity, adduction deformity and external rotation deformity. The treatment would be physiotherapy to mobilize the knee beyond the 90 degrees so that she can at least sit on a chair, if not sit cross-legged or squat. Then I will try to correct the adduction deformity and empower the gluteal muscles so that the Trendelenburg gait would go. I would correct the shortening by block measurement in the shoe, and this would always compensate the undercompensate the true shortening, because if I compensate it completely, the toes may stub the ground during the swing phase. If the deformity is not corrected and the Trendelenburg gait persists and it is not tolerated by the patient, then I will do a subtrochanteric corrective osteotomy where at the cora I can do a closed wedge osteotomy and restore the neck shaft angle of 52 degrees. An open wedge osteotomy and fixing by an angled locking plate would also correct or decrease the shortening. So that could be preferred, but it will increase the cost. In case of a fresh case, I would have splinted the patient and carefully understood the fracture geometry on the X-ray of the pelvis. Then I would have reduced it and preferably fixed it by a dynamic hip screw. The plate component of the dynamic hip screw could have compressed the subtrochanteric component of the fracture, and the DHS component would have compressed the vertical component of the fracture. Alternatively, a PFN would have been given if the patient was of low risk of anesthesia and surgery. An external fixator could have been used. In case even that was not possible, above knee fixed skin traction on Thomas's knee splint could have been given. It could have been a skeletal traction through femoral condyles or tibial tuberosity. The precaution would have been that during this immobilization, the knee should have been at least in 15 to 20 degrees flexion, as that would prevent rotational stress on the fracture and would prevent the knee from getting stiff in a locked position. If in case of an AK splint, I would have watched for absence of active dorsiflexion during the in the post application stage, and this would have indicated a lateral popliteal nerve injury. In such an eventuality, I would have decompressed the nerve at the neck of fibula and given a toe sling to prevent passive limitation of dorsiflexion during the immobilization phase. When the patient would have started to walk, I would have then used the orthotic device to prevent foot drop during the swing phase. It could have been a toe raising appliance. It could have been a below knee caliper with posterior check, and it could have been an ankle foot orthosis. The ankle foot orthosis is not preferred because it would not have allowed passive dorsiflexion. The toe raising appliance could be given in a lady because they wear petticoats. Otherwise, in a person who wears a pant, a toe raising appliance was not desirable. So a below knee caliper with a posterior check till the nerve recovers. I could have monitored the recovery by a strength duration curve or by electromyography and by the March phenomenon and Tinel sign. If after 9 months there was residual paralysis and the nerve did not recover and the foot drop did not recover, I could have done tendon transfers, the extensor hallucis longus, the extensor digitorum longus are synphasic transfers, the tibialis posterior and the peroneus longus could have also produced valgus varus instability. So EHL is the preferred transfer. Operation is called as P-body transfer. All right. In case the tendons were not available, we could have done a bone block like talar bone block, like calcaneal bone block, or we could have done a Lambert-Eudis triple arthrodesis. In Lambert-Eudis triple arthrodesis, the subtaloid joint is fused with talus in complete plantar flexion and the foot in 5 degree of plantar flexion to accommodate the heel. The calcaneonavicular, the talonavicular and the calcaneocuboid joints are also fused. The complication of a Lambert-Eudis triple arthrodesis is non-union at the talonavicular site.